Welcome everyone. For those that haven't met me, my name is Nick Fuggle, and I'm based down at the University of Southampton, where I'm a clinical rheumatologist, and associate professor in musculoskeletal epidemiology. Um, I helped to run this group together with um, Emma Caroon from the Turing, Joe Alderman from University of Birmingham, and Alicia Davies, who's both at the Turing and at the University of Swansea, and does lots of work with Public Health Wales as well. So welcome to our session today. We've got a really exciting program lined up. Excellent. Yeah, we can record that locally as well. And we're going to be starting with just a few notices. So I just wanted to draw your attention to the fact that AI UK is the big Turing conference. So happens every year, used to be virtual, but now is held in Westminster. It's a really good event, and that is on the 19th and 20th of March. So do try and sign up. I think you can attend virtually for some of the sessions, but also there's an in-person event if you can make it down there. So well worth a visit. Second, to say that connected to AI UK, we have a clinical AI fringe event. And I'm sure that if we were in a room together, we'd hear lots of weeping and excitement. But that's going to be held on the 30th of April in the afternoon. Try and keep the date free. Some more details will come out very soon about that, but that's on the horizon. And also, I don't know if Bianca is on the call, but Bianca Shaw is one of the organizers of the AI for Women's Health super group within the clinical AI interest group. And they've got an event coming up on the 7th of March as well. I think that was advertised in our latest newsletter, but 7th of March at 1 p.m. UK time. So worth checking out. Anyway, we've got two exciting 3-minute intros for you today. The first is Ava. Ava Miga. Are you there, Ava? Lovely to
Yes,
see
I
you.
am.
Thank you so much.
Great. Thank you very much. Great to meet you
Thank you for
all.
joining us. So, just for anyone who hasn't come across the 3-minute intros before, they're essentially an opportunity for someone to say who they are, where they come from, and in what way they interact with AI, and also put out any potential asks to the community. So, Ava, welcome. The floor is yours.
Thank you. Yeah, great to meet you all. I'm a bit different background in that I'm not currently an academic, but I am trying to start a startup in this space. So, um, it's a health tech startup and started out as more of a data play. But when I started doing a lot of different market research interviews with patients, what I heard from them was really that patients aren't in the driving seat of their own health. There's a huge amount of work that patients do in terms of managing their own care, be that trying to figure out what's wrong with them, what they should do about it, motivating themselves to seek care, getting, that through the hassle of getting a GP appointment, communicating in a very brief period of time to the doctor what's wrong with them, and trying to convey how serious it is for them and how it impacts their own life, advocating for themselves, remember to take the medication, remember to get a new prescription, maybe doing all of this also for young kids or older parents. But they really don't have a good kind of background and I suppose framework of tools to support them in all of these management activities that they do. And certainly, if you compare the customer service that patients receive in the healthcare system versus what they're used to receiving as consumers in any other industry, they're kind of miles apart. So the initial aim is to develop an app where patients can store their actually often quite complex medical histories, like their own version of them, so that it's very comprehensive and it's inclusive of everything. Let them track any symptoms that they're having, and then be able to present all of that information in a clear chart type readout for their physicians, so that it kind of has a concise summary and they're able to kickstart that discussion a bit better and have a better history taking process and a better conversation from that. And really just empower patients to be able to kind of advocate for themselves. Later on, when we have more data built up, it'd be great then to kind of build out other parts of the journey, so allow patients to understand their treatment options better, and kind of care coordination and so on. And yeah, so that's kind of the initial idea. The kind of idea is that given their strong levels of health engagement, young women and people with kind of complex needs or multiple chronic conditions will be the initial target market. And kind of go from there. The idea is that the data generated by the app, because it will contain very granular patient data, which you wouldn't normally get as much detail in medical records, and it would be holistic, would be very valuable in terms of bringing on the potential of democratizing personalized medicine to a wider audience. And particularly if you're able to correlate that biometric data to, the symptom data to biometric data, such as, age, ethnicity, activity levels, and so on. It could be very useful in terms of trying to cross the gender data gap, and kind of, bring things forward in that regard, and try and, I suppose, synthesize things towards getting more personalized insights and optimizing things for better patient outcomes. So I realize a bit of a long spiel. I'm at the moment kind of looking for people to help me on the journey. So any developers, anyone who's just interested in the topic, any clinicians that are interested in kind of chatting and giving advice or giving time where they can, I'll put my email address in the chat, and we'll be very open to hearing from anyone who is interested or has any thoughts on the idea. Thank you.
Let's round of applause for Ava. Thank you so much for that. That sounds like a fascinating startup, and please do get in touch. Put your email in there, and I'd strongly encourage anyone to get in touch with Ava. Sounds like a really important area that she's working in. And next we've got Rohan. Is Rohan on the call? If he's not, then I think we might be moving on quite swiftly. And it looks like he's not. So I'm going to hand over at this point to Joe. We've gone kind of national as a clinical AI team today, and actually Joe joins us from the Scottish countryside, in the Highlands. Are you in the Highlands?
Just about Argyllshire.
Argyllshire. So from our correspondent in Argyllshire, Joe, would you like to introduce our thematic session?
Yeah, thanks so much, Nick, and thanks everyone. This feels like a bit of a weird one for me, not only because I'm outside, somehow not in the rain in Scotland, but also because I'm introducing some of my colleagues from Birmingham. So I'm not going to dwell too much on introductions. I'm going to let them introduce themselves, but just firstly to say thank you so much to Joe and Al for joining us today. And they're going to be talking to everyone today about some work we've been leading at the University of Birmingham, University Hospitals Birmingham, over the last 18 months or so. So without further ado, I'm going to hand over to Elle and Joe to introduce themselves and to present the rest of the session. Over to you.
Thank you, Joe. I'm just going to share my screen. Hopefully it works. So while that loads up, my name's Elinor. I'm a clinical research fellow at the University Hospitals Birmingham. And together with Joe and a few other people, we've been leading this project called Standing Together, which aims to produce recommendations for dataset diversity, inclusivity, and generalizability. Dr. Joe Palmer is a postdoctoral research fellow, and I have a medical background and have been working in research full-time for about 2.5 years now. And through this talk, I'm hoping to give you an insight into what the project was all about, but also a little bit about how we got here, because I think we often hear about recommendations that are being released by different organizations, but sometimes we don't have such an insight into how they got to where the conclusions that they made. So hopefully we can show you that the recommendations we've produced are supported by quite a lot of evidence, and hopefully that's of interest. So first of all, then, I don't think I need to preach too much about the potential of AI. But I think we can all hope that it could be a real potential for reducing health inequity, for improving clinical workflow, and also providing us new insights into health and disease. And there's obviously real political interest. It's part of the strategy for health for many health systems across the world. But really, I think we all need to be clear that it also needs to be safe and effective. And that's really where we come in with this project. So whilst there is potential in reducing health inequity, there's also potential for AI to worsen health inequity. And that's a really complex balance to reach. And there's growing evidence that actually AI can cause direct harm to people. And one of the most kind of pivotal papers that has been published on that was one of the early papers by Obermeyer, which I'm sure lots of you have seen and heard of, which demonstrated that an algorithm that was in widespread use was systematically discriminating against certain racial groups. And that's clearly just totally unacceptable, and something needs to be done about it if we are to be using AI on a regular basis within healthcare, and for it to reach this potential that everybody hopes it has. And there are lots of reasons why AI can display this sort of bias. But one of the reasons is actually the data that the AI is trained on. And this term, health data poverty, was coined by our group. And the definition is the inability for individuals, groups, or populations to benefit from a discovery or innovation due to insufficient data that are representative of them. So just to unpack that a little bit, if the data that the AI is trained on isn't representative of the target population, then we know that the AI won't work so well for those groups. But it's a really complex process, recording of health data. There are lots of ways that bias can creep into the data through decisions that are made, but also through health inequity to start with. And actually, the important part here is to understand where those biases might have crept in. But we know that actually when you look at data that underpins AI technologies, it's often quite difficult to know where that bias might be, and who the groups at risk of harm might be. And that's really where Standing Together comes in. So the project was set up about 2 years ago now, and includes a really wide range of institutions and professionals across the world. And the aim of the project was to produce recommendations for dataset composition, for people to be reporting what's within their datasets. We want them to be really transparent about how decisions were made, and also be open about how the data is used to create and evaluate the AI. And the hope really is that through this transparency and through this documentation of the processes that underpin the AI, that we can help to reduce dataset bias and also reduce the harm that might come as a result of that. Patient and public involvement was a really huge part of this project, and we feel like it really had a big impact on the direction that we took with certain parts of the project. And we had 3 main ways of incorporating the patient and public voice within our work. So we had 3 patient public co-investigators who were part of our working group. They were really integrated into the team, and we worked with them to deliver all the work packages. But they also acted as quite an important bridge between our wider committee and our working group, because actually sometimes our kind of summary of what was said in meetings perhaps might not align with their perception, and actually that we found that to be really helpful to have people kind of in both camps. We then had a wider patient and public involvement committee, and we met with them quarterly and discussed really complex issues actually about, what would you want to happen if there was a biased algorithm that could potentially be used in a hospital? Would you want it to be used? Would you want it to be used for some people only? And we had some really rich discussions that really impacted our perception of the whole kind of thing. And that then led to certain decisions being made and certain concepts being incorporated within our recommendations. But partway through the project, we had a bit of pushback from some of our working group who were international, because they said, well, you're kind of posing this as an international project. You've involved all these people from all over the world from a professional background, but actually, what about the people on the ground from other countries? Where's your patient and public involvement from elsewhere? And we thought, right, okay, how are we going to do that? Because we hadn't really heard of other projects that had incorporated an international voice within their PPIE strategy. And so we devised a plan to do asynchronous meetings via Slack. We recruited via social media, and we ended up building quite a big network of about 30 people we could then ask questions to. And that was really powerful because they really gave us the insight that we needed into the kind of differences in health data recording practices across the world. So a bit about the project structure more generally. So there were 3 parts of the project. The first was understanding the landscape of health data at the moment. The second was actually building the draft recommendations. And the third was a zoomed out look at what it might mean to the community if the recommendations were released, and that we could gain those insights through interviews with stakeholders. So I'm going to go into some of the findings from work package 1, which was the systematic review of dataset documentation. Now, this is a little bit different to standard systematic reviews in that here we weren't looking to identify papers per se. We were actually looking to identify data sets that had been used to train or test AI algorithms. And we chose priority disease areas. We'd already completed 2 dataset reviews in skin cancer and ophthalmology. And as part of this project, we added on a few extras in COVID, mammography, and heart failure. We went through a normal systematic review process in doing a literature search, but we then looked within those papers that reported AI algorithms being developed and looked at the data sets they were using. And we then kind of looked under the bonnet almost, because we were looking at how they reported things, who was reported within the data sets, which demographic attributes were they including, and we produced a summary then at the end of how many of these parameters these data sets were recording. And I'm going to just focus on one, which is race and ethnicity, to just demonstrate the lack of reporting that was shown. So here's just an infographic for each of the disease areas, and we've got a dot plot here which shows the percentage reporting of race and ethnicity for each disease area in the data sets we identified. And you can clearly see that there's a real lack of reporting of race and ethnicity across the board. And just to caveat this, if a data set had reported, that they'd stated that they couldn't report race or ethnicity for whatever reason, we would have put that down as they had reported because they had mentioned it. So this isn't even people who have said, we haven't been able to record it for whatever reason, because that's very legitimate in some settings. It's not appropriate to be recording these things for some scenarios. But actually, we'd like it if people actually wrote down that why they made that decision not to report it. And I think it's particularly alarming in when you consider that certain disease areas are really, have very relevant attributes associated with them. So, for example, in the skin cancer dataset review, only 2% of the data sets actually wrote down race and ethnicity categories, and that's obviously a huge problem because it's very relevant to the disease area. So overall, there was a lack of reporting of individuals' attributes within data sets. Where the attributes were reported, there is a real lack of diversity within the data. So people aren't represented within there. And thirdly, definitions are rarely provided for these attributes. And that's particularly important when you think of an international perspective, because our perception of what we mean by ethnicity is not the same as, say, in the US. So if people were looking at the data that's underpinning an AI algorithm trained here, and we say, okay, we've trained on ethnicity, it's really important for those people elsewhere to understand what we mean by ethnicity and what categories we've included and how many people are within those categories. We didn't just look at relevant attributes and personal characteristics. We also looked at the wider concept relating to dataset curation. So we looked into whether people reported funding, whether people were talking about how they generated the labels, whether they'd reported any ethical considerations, and actually across the board there was a real lack of reporting of all of these things. And I think really the issue here is that it's really hard to do, and it's really hard to know where to start, because there's so many things that you could potentially report. How do you know what to report? And we hope that that's where standing together can be of real value. So I'm now going to hand over to my colleague Jo, who's going to go into a little bit more about how we got to the recommendations and what we found from our interviews. So over to you, Jo.
Thanks, Elle. So hi everyone. So I'm going to talk to you about how we got to the recommendations. So we started off by undertaking a literature review and a scoping survey. So the aim was to identify from the evidence base what recommendations or best practice statements were already out there and that we should be considering in our recommendations. So the literature review was a typical literature review, and we identified initially 10,000 plus hits. These were all screened, and we had 135 full text articles that we screened for best practice statements, and eventually resulted in 30 of these articles synthesizing the evidence base around what people felt was important. So the survey was included 45 different stakeholders, including dataset curators, academics, clinicians, and medical device regulators. And from both these two sources, we drafted a short list of 30 individual items to be included into the Delphi survey. Next slide, please, Al. So the Delphi consensus method is a method that originated from the military as a forecasting technique, but this was later modified by the RAND Corporation and is now a widespread technique used in policy and healthcare. So for our particular round, we had 3 rounds of surveys where respondents viewed the items and commented and voted. This was followed by a green paper. This is where we did a summary of the draft items that had reached to the round 3. And put that out for public consultation for 4 weeks. We took all this information from the free surveys, and then we fed that into the draft items that were to be considered by the consensus meeting. And the purpose of the consensus meeting was to agree the final items. Next slide, please. So who participated? So we had different stakeholders. We had members of the public, healthcare professionals, people who representing the domains of policy, regulation, law, and we had computer and data scientists. So you can see from the donuts, I think they're officially called, that actually the participants decreases over time, and there's a reason for this. In the Delphi survey, people will only be invited to round 2 who have participated in round 1. So in round 1, as part of the consent process, says participants needed to identify whether they would be happy to be contacted to take part in round 2. So there's a natural reduction of participants over time. I think what's key here is you can see that there wasn't any particular stakeholder group represented who dominated. So next slide, please. So the Delphi consensus study itself, we invited 28 people attended, a 2-day event held in Birmingham. People who attended were regulators from the UK and Australia, I think Canada, and we had the FDA on the phone. Funders, publishers, AI developers, so people from industry, our patient partners, and representatives from WHO and the UK standards body BSI. Each participant, if you can see on the left, is a document. They were given this information about a week before the consensus meeting, where they had the information around what the item was, how that had changed between rounds, and how different stakeholders had voted. We feel that there was a real strength to this approach because it ensured that the discussion was framed in the consensus meeting around all the participant views and wasn't just the views of 28 people. So the participants voted online. They had three options, and an option to include the item, and an option to exclude the item, or an option to abstain. So the abstain vote was there to allow people who didn't feel ready, they could make a decision either way. And we had a criteria. If the abstain vote for each item was greater than 10%, then we asked people who had abstained reasons why they'd abstained. And if necessary, we went back to further discussion, and then we moved to vote again. Sometimes we revisited items at a later time because the participants didn't feel ready, and we reached that higher criteria. So I think one of the biggest challenges of the discussion was timekeeping. Initially, we had the first few items. I think we felt we were going to be there for at least a week rather than 2 days. Took a lot of time. But actually, when you really thought about it, this was where people were demonstrating their position, where they stood. So there was a lot of contextual information in those first few items. So therefore, that actually facilitated the discussion going forward, because people started to see what each stakeholders, what were important to them. And then with excellent chairing, we very swiftly moved through each of the items. And then, of course, Elle won't forgive me unless I mention the merch. So you can see our little standing together mug. Now, I use that flippantly, but everybody liked having their cup and their pen and their pad. But I think the message here is don't underestimate the power of merchandise to having a brand, so that people know what standing together is, and it opens up conversation. So yeah, that was another important concept. So then we move on to the interview study. So the aim of the interview study was to look at the barriers and facilitators to adopting and implementing the recommendations. So we interviewed 29 participants with semi-structured interviews using Zoom. People included were dataset curators or users, or were a combination of both those roles. They represented 14 different countries across 6 continents, and we used framework analysis as our data analysis method. There were 3 key themes. First of all, we was navigating the complexities of the current health data landscape. So this was also exploring some of the issues of what the challenges these recommendations had to accommodate. So some of those big ones are bias. We know that there's known bias, we know that there's unknown bias, but we don't know what that unknown bias is, and that actually the recommendations themselves were not going to be a solution to bias, but they had to be framed in a way that we could describe what bias we knew and also contribute to learning about bias we might not have known about. And another house challenge is framing of, as Al's already mentioned, personal attribute data across the different landscape of countries. These are all defined and categorized very differently. So the standards needed to be flexible to that needs. And then the next thing they talked about was mitigating the risks to privacy, and that itself could have an impact on data integrity and quality. So there was a real issue around having to make trade-off decisions around balancing privacy versus data granulation. And by that we mean we have to aggregate data, and it will give us less information in order to protect an individual. So in the second theme, we started asking about highlighting the barriers to operationalizing and adopting the recommendations. So there were some questions around what were the boundaries, the scope, and the application. So participants were unsure about at what point in the life cycle they should be used, what constitutes best practice. They identified that they needed to be versatile, flexible, that actually all these things change depending on the context. So context was important. And some of the physical obstacles to implement the standard included the actual complexities of the data itself. So thinking about integrating multiple data sets, how do we write these recommendations and documentation if we've pulled our data from very different sources that report report, say, for example, let's take gender, for example, or sex, report those very differently or categorize them differently. And that would be quite an extensive exercise. So they felt that would be a challenge, not impossible to work through, but it would be definitely a challenge. And then there's been the concept of being digital ready. Do they have the infrastructure to support the applying these recommendations? And then there were concerns about this being resource intensive. So enablers of adoption were endorsement by trusted bodies, whether they aligned with existing practices and regulatory requirements, and whether they would be used as a lever for something else. And by that we mean, are they a condition of funding, condition of publishing, or a condition of getting ethical approval? And another clear enabler was clear messaging and really understanding what the purpose of these recommendations were and the gaps that they were to be filling. And then finally, we have the impact. So what was the impact? What did the participants feel were the impact of these recommendations? So key impact was transparency, that it was really useful to have this information to enhance decision making throughout the AI lifecycle process, and that the recommendations are a good tool to improving quality, safety, and equity, promoting harmonizations across data sets, helping make a decision whether the data that they were proposing to use was fit for purpose, whether the AI is safe and inclusive, and whether improve and go on to improve ethical practice. So in a nutshell, responsible AI, that they're actually contributing to the conversation around, is this ethical, is it transparent, and is AI trustworthy? And then we've got improving culture. Over time, the participants felt that the recommendation, the knowledge and the learning and the collaboration this would encourage would shift values and norms and would actually allow us to identify what problems are there and start to look for solutions. However, there was a concern that the value of the data sets, if they didn't comply with the standards, would they then have less value? And then the final impact was the harsh economic realities of implementing recommendations. And there were definite concerns around the lack of resources, and that's financial. That's also about manpower, so boots on the ground to do this work, and also the expertise, and that had a knock-on effect of, we really needed to think about the training aspect of implementing these recommendations. And then finally, that they felt that unless we were careful and there were funds were well distributed, that the standards themselves could be discriminatory, as they could disproportionately affect lower resource settings, leading to an unintended exacerbation of health inequity. So next slide, please, Al. So I think the key messages is the data set bias is inevitable. We're not going to get rid of this. The recommendations are about managing this, and that transparency cannot be optional. And I think a really nice quote actually from one of the participants in the study sums this up. So we're not trying to find a silver bullet. We're trying to fire some silver buckshot. Is this one thing going to fix everything? No, of course not. Is it something we absolutely need and can help with all sorts of conversation? Yes, absolutely. Next slide, please. So our reach. We reached over 350 different representatives from 58 different countries. And whilst this reach is extensive, it should also be acknowledged that we can see on the grey areas, there are areas we did not reach. Next slide, please. So the recommendations themselves, they come in two parts. We have part one, which is aimed at dataset curators. And this is really about understanding the data, the composition of that data, and being transparent about if you like, its flaw, its good points and its bad points. And then there's the part 2, which is aimed at developers and assessors of the AI health technologies. And this is really about how have the developers considered the use of the data set and the implications of that on their AI technology, and in particular looking at risks to groups, different groups of harm, and identifying performance across those groups. Next slide, please. So this is the recommendations. It's only a quick summary overview, but you can really see here from the different items what it's trying to cover, that we're really asking people to tell us about that data. So let's begin. Data set summary is a high-level overview of the data, and is aimed at people going, well, is this data set something I should look further into? Can it address my needs? And it might include things about, you know, who you know, what information is in there. And then we start unpicking the processes behind the data curation and process in terms of data collection, whether they're modifications, whether there's limitations, have we done, you know, what sampling, who's represented in that data, how are they represented, so the composition of the individuals, how are they recorded their attributes, are there limitations, modification, missing data? So missing data might be that missing whole groups. So for example, if no males are included, or might be missing data in terms of the data integrity. So we've collected ethnicity, but only 40% of cases of the cases have ethnicity data in them. And then it's, right, what have you done to that data and how has that changed it? So how have you aggregated that data and the decisions that you have made? How have you assigned, or how has the labels been assigned? By the labels, that is what you're saying that data represents. And then we've got, what ethical framework have you collected? Has this data been collected ethically and appropriately? Were patients and publics voices embedded in this process or not? Were they consulted about how their data was collected and how they were represented? And then bias and impact statements. Have there been former assessments that you looked at and take into account when you've collected this data? And it's all about providing information to the data user and the downstream effects that might have when they're considering using it for their purpose. So next slide, please, Elle. So then we come to part 2, which is aimed at, again, at the dataset AI developers and the assessors of those developed product. So just again draw you to the first item, which is dataset documentation. So what we're asking for the users of these recommendations is to tell us about that data, tell us, and it would be lovely if they have a dataset documentation that sits alongside for that data set, but the reality is in the beginning that's not going to happen. And currently dataset users need to find out as much information about the data set as they can from all different sources, and that has been well documented, but that's a really difficult process. So having part 1 sit alongside a data set that they intend to use has a real benefit. So the point of part 2 is to tell us, for the data set users, to tell us how they've used that data in context to the problem they're hoping that their AI development product is going to be used in. So we use a term called contextualized groups of interest, and so these are people where we know in advance from the, or they should know in advance from the literature, who's at risk of, you know, who needs to be in this group, who needs to be in this, sorry, the intended use population. It's linked to that. Yeah, so who is relevant? Crumbs, I can't get the words out. And yeah, and then they're to tell us what have they done with that data, how they've used it in the, in their processes, and then look at identifying performance and reporting performance across the particular contextualized subgroups of interest, but also wider than that, identify any disparate performance across any additional groups. So, for example, if say, for example, we don't have identified groups that are at risk of harm in the evidence-based existing, then start looking across some personal characteristics for, and see if we can start building an evidence base for whom their device works or doesn't work with. And then also to report methods on how they have modified performance across groups. What have they done? Tell us about what processes and your decisions behind your processes. And I guess this kind of is like lifting up the veil of the black box. We're trying to unpick some of the decision making that sits behind in a lay language, for example. So that's all about identifying to the users of the technology some of the things that they need to be considering and being aware of. Next slide, please, Al. So identified in the stakeholder interviews, a key enabler is endorsement. To date, the standards or recommendations have been endorsed by the UK government at the AI Safety Government Summit, by the MHRA in their Software and AI as a Medical Device Change Programme roadmap, and also currently in the Medical Research Council funding, where applications need to have considered the recommendations in terms of inclusivity in their research. Next slide, please. So you can access the recommendations on our website at www.datadiversity.org/recommendations. This will take you to an external platform, and it's called Zenodo, which is on the left. And there you can download the recommendations. There's a very short guidance with these recommendations available at the moment, but the paper is in editorial process and will be available at some point soon, where you'll be able to access the full guidance that sit alongside the recommendations. Also on the website are the overview findings from the systematic reviews and the data sets that were identified in the systematic reviews. Next slide, please. So that brings me to a close. We are part of, Elle and I are part of the wider team, and Joe, along with Jazz, our project manager, Professor Alistair Denniston and Dr. Xiao Liu. And as mentioned, we had a very large working group that were international, with different stakeholders working with us, and our patient partners. Thank you for listening. If you've got any questions, please don't hesitate to contact us.
Thank you so much, Joe and Elle. That was really fantastic. I can see already we have a question from Kevin in the chat. If anyone else does have any questions, feel free to either pop a hand up or post them in the chat and I can read them out for you. But Kevin, if you're online, did you want to come on and ask your question? If not, I can read it out for you.
Yeah, no, it's fine. It's basically a question you mentioned about, ethical concerns, and I think a lot of lip service is paid to that. So the question I had is, it's about an aspect of the trolleybus problem. It's okay. Well, it's the acceptability of machines making decisions that have adverse outcomes versus humans making those. And the best example is self-driving cars. Americans kill 45,000 people a year on the road, but with their cars. But one self-driving car killed an unlucky pedestrian once, and there was an enormous furore about it. And it's not just about the ethics, it's about the acceptability to the right unwashed, for want of a better word, of machines making decisions that have adverse consequences. Did that come up in your deliberations?
I'll take that out. No, and the reason being for that, we weren't looking at whether it's appropriate to use the AI technology or not. We were merely looking at, and so I don't think the recommendations directly address that issue, but I think indirectly they might serve as a tool to give people and the public confidence that the appropriate ethical considerations have been considered much earlier upstream. I mean, you're never going to, you can only mitigate against risk and not reduce it altogether. So yeah, it wasn't something that people were thinking about in our interviews per se.
I mean, that I find that interesting because it's the acceptability of the decision-making processes that's really the problem, I think, in an AI. I think all the other issues you're talking about are very well understood, but I think I have seen very little talked about, dealing with the very human, it's like the human-computer interface issue. How acceptable is this? And we're not very good at judging risk in general, right? So I think that drives that, right?
Yeah, no, and I hear where you're coming from, but I think until the recommendations are out there and being used, then we'll get an idea of whether they're doing what they said on the tin and are building that trust or not towards acceptability that actually we've really considered before we've even got to the device being used in practice about, if you like, thinking about the ethical issues behind it. But yeah, I think that definitely was not covered in this work.
Thanks very much. So we've got a few more questions come in. So question around how we can allow early engagement with MHRA regulators. What I'll do is I'll post a few links in response to that question. So there are a few great websites and resources the MHRA produce. So we'll go to Rory and then to Sedalia, if that's all right. So Rory, you first, if that's okay.
Thanks. Yeah, thanks for a really interesting talk. Just hopefully a simple question. What were the frequent justifications for not reporting ethnicity?
So just a blanket statement that there were no justifications for not reporting it. But I think from our engagement with people from across the world, particularly in our international PPIE engagement, we found that in some places it's literally illegal to report these things. And yeah, I think that those countries are going through a process of grappling with this kind of historical legal process of not reporting it, but then the need to have it because actually the health inequity is there and we need to know that. So yeah, I think from a legal perspective in some jurisdictions, that's probably the reason. But most of the time, no justification was given.
That's interesting.
And is it Sedalia or Cadelia to you?
Hi, Joe. It's Sedalia, but thanks. This is very interesting, and I participated in a few hackathons around bias in healthcare, and I'm actually almost publishing my paper a little bit around this as well. I think the key takeaway from this is actually where does it stand the decision-making process of clinicians? And I think we should see the AI as a complement rather than the only decision-making process of this, especially because the electronic medical records have a lot of missing data, have a lot of bias. Sometimes we're training models on copies of models of the public health data, so it's not even on the data itself. So I think here the key thing is when and how can we teach clinicians and other professionals that are working in this space to actually ask the right questions. First of all, what data was included, how transparent the data it is on clinical trials on this. I think you should, if you are really interested on this, you should reach out to Leo Selly, a professor at the MIT. He's doing a lot of work in this field, but actually is asking all these questions and saying to clinicians that you should not trust 100% on the data, or at least, this data was trained on this, So be aware, be careful on this. And this is issues across different models that are implemented in the NHS. It doesn't have to be a AI machine learning model. It can be a predicted model or economic model. You know, all the models have flaws. So, but I think it's about raising awareness of those flaws and actually empower clinicians to also don't forget that actually decision-making process is very important. And the AI model is probably there to fast pace on those cases that have been trained well. We have really good scores. We have really good data, and you know, it's representative and is generalizable to that specific population. And then we can take more considerations on the other populations that haven't been trained on. And in related with data on health inequalities, we looked at the data in the Norwegian space, and it's been very interesting. For example, they don't collect any data around ethnicities, nationalities. So we didn't have any data on the set that we had to really come to. So that actually was very interesting and actually can drive policy towards, actually this data is very important. And in the NHS, we're very lucky because we collect all this data, and now we can, you know, we can have the first insights on into, you know, what's really going on. Is there any differences? What are the health inequalities across different other variables? So yeah, that's what I would leave the discussion. It's thank you so much for sharing your work.
I'm just going to come back on that because, yeah, you brought up some really interesting points there. And I think the first one is about education and about how the recommendations we've produced could potentially serve as a really useful tool for educators in, you know, in universities, in medical settings. And that's really somewhere that we're going to look to target as part of our dissemination plan. And then secondly, the concept about, you know, in some places where it's not legal to report this information. We've had a lot of discussions, and it came out as part of the interviews that actually these recommendations could be almost like a leverage for people to say, look, actually, we really need this information, and in certain settings, it might be appropriate for us to report this. And it might help people going through ethical processes to actually justify why they might need that data. So we're really hoping that it'll be useful in lots of different settings. And we're not looking to prescribe this. We're not looking to say this is how they should be used. People can kind of take them and use them to whatever effect they see fit, really.
Great, thank you so much. So we had another question in the chat. I think from I've now lost it. Ashley, do you want to come to yourself, Ashley? Then we'll go to Ben.
Yes, thanks very much. I think great presentation. And this is really following a bit on from what Sedada was mentioning before. I was actually wondering, was there much discussion around dataset availability in terms of making datasets available for this type of assessment more broadly to researchers, both in terms of assessing these parameters that for which could lead to bias, but also for retraining models. And I'd be very interested in seeing whether discussions were had at these forums for that.
As part of the dataset review that we did, we obviously looked at the accessibility of datasets, and we categorized different datasets according to their accessibility. And the ones that we could access, we looked into in a lot more depth because we could look into the actual data. And I would say that it's quite variable depending on the disease type. So mammography, for example, is one that's been around for quite a while. People have been using AI in that space for a long time. And it almost seems like because of that, there's quite a lot of legacy open access data sets that people are using for training. But on the flip side, heart failure, for example, is a space that's a little bit newer with prediction models and things like that. And actually, that's like almost like a different landscape because these open access data sets are a bit newer, but they've all kind of come from prospective trials. So yeah, I would say that the data set availability varies depending on the disease area, and there's definitely a push for more accessibility. It's a problem that we found that a lot of the data sets we identified were not open access or accessible, even if they said they were. And I'm definitely a believer that making these data sets accessible is a good thing. But we've also just got to be very wary that, you know, a lot of the time this is sensitive data, and there are lots of governance and ethical issues relating to that. So it's a fine balance that we're still kind of trying to find, I think. I hope that answers your question.
Thank you. That did. Thank you.
Thanks. So we'll go to Ben next, if that's okay. Ben, over to you.
Thanks both. That was really interesting. I was just wondering, there's been kind of discussion recently in a couple of papers around the potential for new generative AI approaches and the use of synthetic data to effectively increase equality across data sets, where you have either, you know, underrepresented populations or perhaps a slew of missing data for certain characteristics. And there's obvious risks with doing this, but if this is something which is beginning to happen, how do you think your framework and recommendations could be applied to those sort of approaches as well?
You want me to take that, Al? Well, I still think that they have relevance because it doesn't specify whether that data set is collected from healthcare or whether it was generated from synthetic data. The point of the recommendations will be, I guess, to be transparent about that fact, and still you would still consider all the usual considerations in the items you would still apply to a synthetic data set. So I think that they do have applicability. I'm not sure when we developed them, we thought about those types of data sets specifically, but I can see them still having a purpose to be able to be transparent about, you know, how people have chosen, why they've chosen a synthetic data set, why it's relevant for the purpose, and what are the decisions makings behind that, and what are the implications of those decisions, if that makes sense. I don't know if anyone else has anything to add to that, Joe or El.
No, that's good. Thanks, Joe. So we got a couple more questions, but I'm aware we're coming up close to time. So maybe if we take these last two quickly, and then I'll hand back to Nick if that's okay. Beatrice, your question?
Oh, just a curiosity. I was curious to ask whether the data sets that you selected were used to support application for the use of the AI tool as a software for medical device, or whether you used any type of data sets.
Yeah, that's a really interesting point, and it's something that I would have loved to have looked into. But unfortunately, the reporting of what AI devices are being used and what data sets they've used is quite difficult to navigate. So the FDA have got their kind of list, but it's really clunky to go through, and I tried, but yeah, it wasn't quite so simple to kind of prove the link, because sometimes the names of these algorithms isn't the same on the FDA approval as it is on the paper, and yeah, there's lots of complexities around that. But we'd hope that through the methods that we use, we captured pretty much, you know, as many as we could, and hope, you know, I would have thought that some of them are the ones that have been approved in the FDA, for example. So yeah, can't be certain, but likely.
Thank you.
Thanks both. I'm aware we're now very close to time. So Nick, I'm going to hand back to you, but maybe we'll write a response to Kevin in the chat.
Brilliant. Yes. Thank you so much. A huge round of applause for Elinor and Joe. That was really fascinating and stimulated a huge amount of discussion. And actually, Ben Will's question that just came in about the potential use of generative AI technologies in order to try and address some of these problems with health inequalities is actually the subject of our talk next month. So we're going to be joined by Venet Osmani, who's going to be talking to us about the use of generative AI for clinical data and whether it can be used potentially within this space in order to expand underrepresented populations. So a definite theme running here. Thank you again to Elinor and Joe. Thank you to Ava for being our 3-minute intro. Thank you to Joe, Emma and Alicia for hosting as well, and look forward to seeing you all next month, which is on I think it's the 12th, Tuesday the 12th of March at 12 p.m. So look forward to seeing you there. I've also, if you're an emergency medicine specialist, I've just dropped a little message into the chat. If anyone's interested in an emergency medicine event that's coming up, please do just drop me a line and I'll forward you some details. Okay, see you soon.